Hello.
Good. Okay, so I know we have done the exercise stress echo. We have looked at the exercise stress echo, and this would be a good time for you guys to revise that. We're going to discuss coronary artery disease in a couple of lectures. In your echo tests and when you're doing echoes, you're going to get a lot of referrals for possible coronary artery disease or established coronary artery disease. So this is something you have to have a fairly good understanding on. Okay, so what we're going to do is define what we mean by coronary artery disease. Uh, we have to revise or review the coronary artery anatomy because when we talk about, if we say a heart attack, it's a specific distribution. It's a specific blood vessel we're talking about. Because when you get a heart attack, it's one of the blood vessels around the heart. And as you know, there are three main blood vessel distribution. There are branches of those different blood vessels, however, but there are three main blood vessel distribution around the heart. And you have to have an idea of the segments that those blood vessels apply. Uh, we're going to discuss the clinical presentation, how those patient presents to their the doctor, the emergency room, or wherever. Look at risk factors for coronary artery disease and how you can use echo to help you uh, not only diagnose but to follow these patients. Echo is crucial um, in making the assessment of coronary artery disease and following these patients, because if you have someone with coronary artery disease and the ejection fraction is falling, then you have to institute certain measures to change that. Um, we're gonna close the lecture series by looking at what is myocardial performance index. Again, this is one form of assessing the cardiac function. We're going to look at DPDT. It's another form of assessing cardiac function. And then we'll end with mechanical complications of acute myocardial infarction. So these are the different areas we're going to cover. So when we say coronary artery disease, what are we talking about? It's basically the layman term for blockage of the blood vessel around the heart. People say blockage. So basic pathophysiology is the wall of these blood vessels, in kids, relatively smooth and there's no plaques. But as the older you get, then there's buildup of plaques. What happens is uh, you have circulating LDL. So we have cholesterol. We have the bad cholesterol and the good cholesterol. The bad cholesterol is LDL, low density lipoprotein cholesterol. These LDL circulates and they become oxidized, and when they become oxidized, then they're easily taken up into the wall of the blood vessel. They're eaten up by phagocytes and they grow to form what we call foam cells. These are the early plaque formation, and then the process continues and the plaque get larger and larger and larger. So one strategy to reduce coronary artery disease is to reduce the LDL cholesterol. If you can also prevent the oxidization of these LDL cholesterol, then, but one of common strategies is to reduce the LDL cholesterol. So when these plaques build up on the wall of the blood vessel, a number of things can happen. They can just grow and grow and grow and then cause significant blockage of the blood vessel. When they block the blood vessel, they're gonna decrease blood flow downstream. So therefore, the muscle, what we call that, the muscle become ischemic. It's not gonna get sufficient blood supply, and it's not gonna get sufficient oxygen and nourishment. So the muscle is not gonna move properly. And we talk about the different stage of muscle dysfunction. We talk about hypokinesis, and we talk about akinesis, and then you have dyskinesis as well. So these are the different uh, reaction of the muscle to decrease blood flow. However, you can get an abrupt rupture of these plaques, and the plaques that usually rupture is the ones that are not very tight, surprisingly. So these plaque, we call them unstable plaque, and they tend to have a lot of, they're rich in lipids, and they can burst. When these plaque burst, then there's rapid blood clot formation on top of the plaque, because they release certain substances that promote clotting, and that's when you get an acute myocardial infarction, heart attack. So when the plaque builds up, you can get a gradual decrease in blood flow, or you can get an abrupt cessation of blood flow when the plaque ruptures and you have blood clot formation. So those are the different types of coronary artery disease. And we're talking about the blood vessels on the surface of the heart. So if you want to revise the anatomy, remember, so there are basically three main blood vessel distribution. And remember, these blood vessels comes off the coronary, the sinus of Valsalva, where you have the aortic root. So at the right sinus, you have the right coronary artery comes off, and then the right coronary artery have its branches, okay? And then from the left coronary sinus, you have the left main coronary artery, and the left main is going to divide into left anterior descending coronary artery and a left circumflex coronary artery. So there are three main blood vessel distribution, and you need to know the segments that they supply. You need to know the segments. So when we did echo, we always talk about the segments, and we talk about a 16 or a 17 segment heart. Okay. So again, so the circumflex loops around the back of the heart. Okay, all right. So this is the process that we're talking about. So young kids, the blood vessel lumen is relatively smooth. There's no impediment to blood flow. So it's a normal coronary artery. But when you have a little excess of LDL cholesterol, become oxidized, it's taken up into the wall of the blood vessels. It becomes eaten up by phagocytes, macrophages forming foam cells, and these foam cells gradually get larger and larger. You get these plaque. So the plaque forms in the wall and it compromises the lumen. So if you were to look on a cross-sectional blood vessel, it would normally look like this. But when you have plaque buildup right here, then you can see that the lumen is compromised, and decreased blood flow, the heart muscle is not going to get sufficient blood supply. So it will become ischemic. So the clinical presentation is chest discomfort, tightness, pressure, burning, something like that. But when you look at the echo, if it's if the decrease in blood flow is significant, you may get hypokinesis, which, remember, the definition for that is the muscle doesn't thicken to the full extent that it should. And then akinesis, you have no thickening at all. So it's not actual movement, because the akinetic segment can be pulled by a normal segment and appears to have normal motion, but if you look at it carefully, it's not thickening. Okay? So again, the presentation, the clinical presentation, you might be working the patient out for something else, and you find that they have blockage, so incidental presentation. Okay, so you you pick these patients up by not intentional. You didn't go looking for that. Then we talk about the myocardial infarction, which is a heart attack. So the plaque ruptures. When the plaque ruptures, so remember the plaque that ruptures is, remember when you have a plaque, you have a cap on the plaque. I said if the cap on the plaque is very thin, at the corner of the plaque um, tend to rupture as well. And if the plaque contain a lot of lipids, fat, then it tends to, we talk about an unstable plaque and it can rupture. When it ruptures, then it leaves these material which will promote clotting. So you get platelet clumping on top of that and completely blocks the blood vessel. So you get a heart attack or a myocardial infarction. Or if you just get chronic decrease in blood flow, you get angina, and the angina can be either unstable, that is, short, uh, it's a short duration, or the pain that the patient usually have is occurring at shorter distance or exertion, lasting longer. Okay, so the unstable angina, or can be a stable angina. Okay, they usually walk 6 months before they get chest discomfort, and they continue to have that, a stable angina. Sudden cardiac death also is one of the presentation of coronary artery disease, because if there's decreased blood flow to the muscle and the muscle becomes ischemic, it can become very irritable, and these patients are prone to have ventricular tachycardia and ventricular fibrillations, and they can have sudden cardiac death. So if someone presents with sudden cardiac death, they need a cardiac catheterization. Uh, you know, right. So, and then heart failure, because remember that one of the leading cause of heart failure, mainly systolic heart failure and diastolic heart failure to some extent, is ischemic heart disease. If significant portion of the muscle have decreased blood flow, then it becomes weak and it doesn't contract properly. So in your echo practice, you're going to see a lot of indications for coronary artery disease. So bear that in mind. So the standard risk factors: age, the older one gets, the more prone they are to coronary artery disease, heart attack, stuff like that. Smoking, a very strong risk factor. Uh, Dyslipidemia, remember we talked about uh, high levels of LDL cholesterol and also decreased HDL cholesterol. Hypertension, we did our lecture series on hypertension, and we state that hypertension is one of major risk factor for cardiovascular disease, diabetes mellitus, obesity, and a family history. So these are some of the more common risk factors. So you can do risk assessment, and there are different type of scores, multiple different scores that you can use to do risk assessment. Remember we spoke about the atherosclerotic cardiovascular disease risk score, and it look at these things. So most of the risk scores, that the gray score, whatever score you're going to look at, the Seattle R score, they look at age, they look at cholesterol, smoking, blood pressure, diabetes. Um, okay. So the echo now is very crucial, because we're talking about blood flow to the heart muscle. So if the heart muscle is not getting sufficient blood supply, it's not going to thicken properly. And if sufficient, if a large section of the heart muscle is not getting sufficient blood flow, then it's going to impact on the ejection fraction. So the overall ejection fraction can and will fall. Again, coronary artery disease is one of the leading causes for heart failure with reduced ejection fraction. Okay, so look for wall motion abnormality, and remember, it's not necessary motion, because you can have an hypo or akinetic segment with normal motion because it's been pulled by the normal segment, the adjacent normal segment. Okay, but ejection fraction, uh, it tells you a lot about a blockage. Again, the systolic function may be reduced, but it can be normal. It's coronary artery disease is one of the leading causes of diastolic dysfunction as well. So if you look at this patient, you can see that the ejection fraction, well, this is a parasternal axis view, but the you can see the ejection fraction is down. But look at the septum. It's akinetic. It's you see this. It's not thickening at all. So this is what we call akinesis. The posterior wall is thickening efficiently. So, and then look at the apex. Look at the apex here. The apex is akinetic. You have akinesis of the base. Okay, so, and then you can do your Doppler studies to look at diastolic function and dysfunction. You need to do all your views. So you do all your views. So remember your two-chamber, your apical, two-chamber views, because you want to look at all the segments. Okay, so, and what we'll do, I think we have a little revision of going over the segments, so you have to be familiar with the segments. So if someone presents with chest discomfort and you suspect coronary artery disease, if there's no contraindication to exercise, you can do exercise stress echo, as we have pointed out before. You can do either the treadmill or the bicycle. If the patient cannot exercise for whatever reason, then you can do a dobutamine stress echo. We went over stress testing. Now, let's review the coronary artery territories and the segments. Okay, so all right, let's look at so when we look at our short axis, so the short axis at the apex, okay, the top is the anterior wall, this is the inferior wall, this is the lateral wall, and this is the septum. So this is just a revision of the segments, because this is something that you guys have done before. So short axis, and you cut the heart at the apex, you just have 4 segments: anterior, inferior, lateral, and septum. So you can say this is the it's color coded LAD. So you can see that the anterior and the septum supplied by the LAD. So these, in the apical short axis view, the anterior and the septum is supplied by the LAD. The inferior is the RCA, as you can see, and then the lateral is the left circumflex. So all you need to do is have an idea. You don't have to have have it down 100% correct. So at the mid level in the short axis, so the mid level is where you have the papillary muscles, remember? So short axis at the mid cavity level, there are 6 segments. So this is the anterior wall, this is the inferior wall, this is the lateral wall, but it's divided into an anterior lateral and an inferior lateral. So the lateral wall is divided into 2 segments, the anterior lateral and the inferior lateral. And the septum is over here, and similarly is divided into an anterior septum and an inferior septum. And then you can look at the blood vessel distribution. So the anterior and the anterior septal, LAD, okay, left anterior descending coronary artery. when we talk about the inferior septum and the inferior wall, that's the RCA, okay? And then at the base is where you have the mitral valve, and you also have 6 segments at the base. So you have the anterior wall, the inferior wall, the lateral wall again is divided into anterior lateral and the inferior lateral. The septum, anterior septum, inferior septum, and the coronary distribution is similar to the mid-level. So the LAD is the anterior and the anterior septum. The RCA is the inferior septum and the inferior. And then the anterior lateral and the inferior lateral is the left circumflex. So you see that, okay? And then, the apical cap, this is 17 segment apical cap, is a LAD. So these are your coronary artery territories. And then for the apical views, so for the apical views, you need to remember those segments. So let me quickly draw the apical segments so that we don't miss anything. All right, so let's look at when you look at the 4-chamber view. And the right ventricle is over here. Okay, so this is your 4-chamber view. All right, and this is the lateral wall over here. Okay, so and close towards the mitral valve, that's the base of the heart. Okay, so this would be your basal. So this is going to be your basal lateral wall. Okay, this is the mid. So this is the mid lateral wall. And then towards the apex, the apical lateral wall. And then this is the septum, okay? So again, close to the mitral valve, it's your basal septum, and this is actually inferior septum. So this is your basal septum. And then this is the mid septum. And then this is your apical septum. And then, you have the apical cap, which is right here. Apical cap. The apical cap is LAD distribution. Okay, so this is the apical 4-chamber view, and then you have your apical 2-chamber view. So, view. So this is the inferior wall here, and this is the anterior wall. So again, anything close to the mitral valve. So this is your basal inferior wall. Okay, so this segment right down here is your basal inferior wall. Then this segment is your mid inferior wall. And then this would be your apical inferior wall. So this is your apical inferior wall. Okay, so this is the anterior wall. So similarly, you're going to have the basal anterior wall, the first segment, then the mid anterior wall, then the apical anterior wall, and then you have the apical cap. So this will be your basal anterior wall, this is your mid anterior wall, and then this is the apical anterior wall. This is the apical cap right there. So you have to be familiar with the segments because you need to have an idea of the blood vessel distribution of the different segments. Okay. All right. So, and remember, we did our stress test how to look at how to evaluate the stress test. So we're going to quickly go over that. So you're supposed to review those things. All right. So again, when you look at your resting image and the stress image, if the resting image is normal and the stress image is hyperdynamic, then that's normal. The heart, when someone exercises, the heart muscle support, the thickness supposed to increase and the motion supposed to be increased. So that's a normal response. Uh, at rest, it's normal, and when you exercise or any type of stress, if there's wall motion abnormality, hypokinesis, akinesis, or dyskinesis, then that's a definition of ischemia. And if you have wall motion abnormality at rest and it worsens with exercise, then that's also ischemia. If you have wall motion abnormality at rest and it's unchanged, then that's scarred as a heart attack. So that it's a heart attack with scarring. So scar is not going to thicken, and so that's a scar. If it's akinesis and then become dyskinesis, also a scar, infarct. Remember, if you have wall motion abnormality at rest, it improves with low dose dobutamine, and it becomes abnormal again with peak dobutamine. Then that's a biphasic response, and it suggests that you have valvular myocardium. So we went over that as well. So with dobutamine, you can look for valvular myocardium. So if you're doing a dobutamine stress test on someone with an ejection fraction of 20%, the thing is, not all the muscle is going to be dead. So if you plan to do an intervention, bypass surgery or a stent procedure, you have to make sure that you're going to work in an area that the heart muscle can improve. You don't want to do a procedure and there's not going to be any benefit. So that's why we'll do what we call viability studies. And you can use the dobutamine stress echo to look at viability. Again, it's a biphasic response. So patient have an ejection fraction of 20% at rest. With low dose dobutamine, the ejection fraction may improve to 40, 50%. But when you go to peak dobutamine, it falls back down to 20%. So that biphasic response, and it suggests that there's valvular myocardium because you can't move from 20 to 50 or 40% with dead muscle. Remember, dead muscle is not going to contract. So there have to be some viable muscle in that 20%. Okay, so again, if you have wall motion abnormality at rest and that improves with stress, then that's suggestive of a cardiomyopathy. So those are the different stress test results that we spoke about. All right. So these are some other parameters that we use to evaluate myocardial function. And one of them is the MPI, Myocardial Performance Index. The other name for that is the TI index, or the MPI, Myocardial Performance Index. and it assesses the overall myocardial function, that is both systolic and diastolic function. We can either use tissue Doppler, or we can use pulse wave Doppler to look at the MPI. If we're looking at the left side, then we're talking about the left ventricular index of myocardial performance, the LIMP. If we look at the right side, if we look at the right side function, then we look at the RV index of myocardial performance, RIMP. So these are some additional assessments that you can use to look at myocardial performance. So let's look at LIMP. Okay, again, TI index for those of you who are doing exams, they might not tell you it's myocardial performance index. They might just say TI index and ask you a very simple question about it. Yeah, so you have to know the other name. So what we do, we put the sample volume at the mitral leaflet tips in the apical four-chamber view, and we're going to look at mitral valve closure and mitral valve opening. Okay, and so the important thing about LIMP is to know the definition. Okay, so again, we're going to look at the mitral inflow, and we're going to look at, so remember, when you look at your Doppler, you can see clearly your mitral inflow, or where the mitral valve opens and where the mitral valve closes. So we will review that so you can, visualize it. And then we also look at the LVOT in the five-chamber view and look at the ejection time, because the definition involves that. So this is the definition. So the definition for myocardial performance index, or the TI index, is mitral valve closure to the mitral valve opening. Okay, so it is that period from the mitral valve closure to the mitral valve opening, and you're going to subtract from that the ejection time, and you're going to divide that by the ejection time. So all right, so if you look at your Doppler, your mitral inflow Doppler, so the mitral valve opens, you have your E velocity, rapid filling, and then your diastasis, then your atrial contraction, then the mitral valve close. Okay, so the mitral valve close all of this period of time, the mitral valve is closed. Then the mitral valve opens again. Remember, the definition is mitral valve closure to mitral valve opening. So that is this duration. It's a time thing. The whole thing is time. So from mitral valve closure to mitral valve opening, that's this duration. And we're going to subtract from that the ejection time. So when you look at your LVOT, this is your LVOT flow. This is the ejection time. So it's the flow starts here and it stops there. So this total period is ejection time. So you're going to subtract. So the duration here is, say, A, and you're going to subtract from it B, which is ejection time. But if you look closely and you remember your intervals, you know that from mitral valve closure to when you get ejection, that's the IVCT, isovolumic contraction time. And then when you have flow cessation, from flow cessation to the mitral valve open, that's your IVRT, isovolumic relaxation time. Okay, so you just revision, you should know these times. So if you have A and you're going to subtract B from A, what you're going to have is isovolumetric contraction time plus isovolumetric relaxation time, and you're going to divide it by the ejection time. So that is why you end up with IVCT plus IVRT divided by the ejection time. But you have to remember the definition of myocardial performance index. It is from mitral valve closure to mitral valve opening. You're going to subtract from that the ejection time or period, and you're going to divide by the ejection time or period. But this is put in a graphical format, looking at the Dopplers. It's self-explanatory. So let's stop here, and then our next session we'll look at the how to use MPI or TI index to assess myocardial function. Okay, so knowing the definition is key. You know that if you don't know the definition, then you don't know how to do how to calculate it. So knowing the definition is a very good start, or is probably the only start.